computer. Hi, everyone. Welcome back. We are on episode 4 of the Cell Bowl 2021. So excited about what we're talking about today. We are talking about who is making it to the playoffs. And what are the playoffs? Well, it's to decide who ends up going to the Super Cell Bowl this year in week 7. So next week, we're going to be talking about who is making it to places 4 through 6. And then in week 6, we're going to talk about who is in 3rd place. And then in our last episode, in episode 7, week 7, we are going to find out who is 1 and 2. So really exciting things that are happening today. And I am really excited to have another special guest with us today. She is so awesome and she loves the lab so much. Her last name even is a cheer for the lab. It's Go Lab. All right. So we've got Catherine Go Lab with us today. Yeah, Go Lab. So we've been really excited to talk with her. She is our hematology expert from the bench this week. We have Erin Odegaard joining us again, our resident micro expert today, and official dad joke winner in ASCP, just to make sure that we're hitting all of those jokes about football and making them hematology oriented. So how is everybody doing today?
Hey.
We're doing good.
Yeah.
Doing great. Yeah.
So Erin, could you tell us a little bit more about Catherine, our wonderful guest today?
Man, I would love to. So Catherine is, I don't know how she does it all. She currently is the ASCP social media committee vice chair. So she had a real busy week with our annual meeting this past week. She's also an ASCLS Wisconsin board member at large. And if that's not enough, she's a 3rd-year Rutgers Dcls student and a extremely active career ambassador. So I don't know how you're awake, how you do it all.
I don't know how I am either, Erin, honestly.
I'm very excited to have you.
Yeah, I'm really excited to be here. This is honestly a dream. I love talking hematology, and I love, sharing my love of this little section of the laboratory. So I'm glad to be here on this week's episode.
And we are so happy to have you and thankful to have you because you are an expert in what we're talking about today. So before we get to that, though, there are some questions that I have that I know students are burning to ask you about. Why did you choose to go into the DCLS program at Rutgers? If you can give us a little information about that and how it pertains to your overall professional goal.
Of course. So the big call for the DCLS for me was being able to help providers with education about laboratory orders. I got to know Dr. Brandy Gunsless, the first DCLS, really well a couple of years ago at the ASCLS annual meeting. And I heard her talk about her laboratory utilization efforts, and that really kind of just struck a chord because as anybody who's been on the bench for a while can relate to, you get those calls from providers like, hey, does this interfere with this test that I ordered? Or, hey, what does this result actually mean? And to have an actual career in being the person who helps educate providers and answer those questions was really, kind of a dream come true. So I applied right away, got into Rutgers, and have started on that journey. Hopefully, as my residency year comes around in 2023, I plan on working with the head of hematologic malignancies at our hospital to review utilization and ordering practices on our bone marrow transplant and hematology oncology floors at our hospital to make sure that the ordering practices for our acute leukemia patients and our bone marrow transplant patients are appropriate, because we know that he knows that, and we know that's a big area of waste. And we're really looking forward to collaborating together to make sure that we are doing the best by that particular group of patients.
So anybody who's watching, that's really awesome, Catherine. Thank you. Anybody who's watching will probably be thinking, oh my gosh, she's in Wisconsin and Rutgers is in New Jersey. What is happening there? So it is an online program. And my question for you is, because I thought about getting into that program, by the way, but I have not applied. I figured out something else. But So it is an online program, and they had always said that, you know, you have your final year being in full-time, basically in a institution area. So before, like years and years ago when I was looking at it, I think it was even before Brandy had graduated, it was that you had to be there. So are they allowing you to get the institution that you want, that is close by your house, and make it so that it's basically suitable to NACLS, right? Because they're going for NACLS accreditation. So
one of the key things for creating a residency site for the DCLS is it has to be affiliated to a medical college, or it has to be to a medical educational institute. So thankfully, the laboratory I work at Wisconsin Diagnostic Laboratories, we're affiliated with Froedtert and the Medical College of Wisconsin. The main medical college campus is on our campus as well. And so Rutgers and MCW will enter into an educational agreement. Rutgers guides my education. They're the faculty for my education. They make sure that I do what I need to do during my residency. And MCW is kind of the site guide. So they're like, oh, she needs to be rotating with this care team. She needs to be rotating with infectious disease this week. They contact the head of infectious disease and make the arrangements for me to be with them. But they don't necessarily do my education. That is entirely with Rutgers.
And so I also heard that you don't really have particularly any textbooks. It's more of journals that you're looking into and updated practices and what's new. Is that true?
So currently for me right now, I am in my didactic, or, you know, my schoolwork portion of my education. And we are using textbooks, but we also do a lot of journal reading as supplemental reading. So for one of my weeks in my education, we learn about thrombosis, so about blood clots. And we read the chapter in either Rodax or Williams Hematology about platelets and thrombosis. And then there are all these new journal articles about different diseases or case presentations or new therapies for thrombosis. And we read those as a supplement. So that way then we have a well-rounded education. So it's a combination of both, because it is learning the advanced bench practice or the advanced theoretical practice for each of the different areas of the lab, as well as then incorporating clinical practice into it.
Very cool. So you heard it, ladies and gentlemen. The textbooks that you have been using in class are what is being used by DCLS programs also. And that's the one actually that I've been using to make the posters that we've been presenting. So yay, you're already ready. Go into DCLS. It's awesome. So I think there is another cool connection with you and the lab besides your name. Is there something you'd like to tell us?
Family connection?
Yeah, so I'll share my screen really quick so you guys can see it. This is a really old journal article from Laboratory Medicine, which is an ASCP publication from back in 1973. And I happened to come across these articles actually by chance. But it turns out my great aunt, so my grandpa's sister, who I knew was a medical technologist, actually also used to work on staff with ASCP. She was the manager of the Educational Center programs, which is how ASCP did some of their continuing education programs for their doctors. So this picture of her here is actually her coordinating microscope placement in this educational center for their program on ear, nose, and throat pathology, which this is just such a cool thing to happen across. And as soon as I saw these, I had to call my dad actually, because I'm like, that can't be my great aunt. Like, that can't be her. But who else would be, you know, Bernadette Golab? Like, that's such a unique name. And there's another article out there that talks about her educational history. And I'm like, call my dad, I'm like, did she graduate from this college? And he's just like, yeah, she did. So I ended up calling her the next day, and I'm like, hey, did you used to work for ASCP? And we had this great conversation, you know, about her time with ASCP and her, you know, work with the educational center. And It's actually how she met her husband, was through ASCP at an annual meeting. So it was a really cool connection to make.
Very
And
cool.
I'm really glad I had that conversation with her. Yeah.
Very, very cool. So I
Yeah.
also want to address one more elephant in the room. So we all are wearing some awesome t-shirts today.
Mhm.
And so yes, Catherine has the virtual race and Erin has the Avengers of the Lab. And so Avengers of the Lab was last year with our lab week for ASCP.
Yeah.
And I think the hematology race was 2 years ago, right? Was it
It was
19?
in 2020.
2020.
So
Okay.
yes.
So we did that too. The girls and I did, and we did a big thing. It was great that it was something that we could do during the pandemic, right? And
Yes.
everybody could get outside and really make a big deal out of Lab Week.
Mhm.
So that is every year. It is ASCLS, and I've been trying to get them to use the virtual race company that I use, because they have this really great opportunity where you are in you're in a race and you're in a location, and so they take you around using Google Maps, and so you're really in that location. You can see around and everything, and at different spots it gives you an informational piece. And I thought, hey, we could make videos about different parts of the lab, and
Mhm.
then, you know, have the race of in the specimen, you know, where it goes from
Yeah.
collection all the way
Oh,
through.
that'd be pretty cool.
That would be
Yeah.
cool.
So if you're in a position to make that happen, I have talked to people already at ASCLS, but
I don't
why
know if
not
I'm your
put it out there?
person.
And so what I'm wearing today is actually the holiday line from Medical Lab Lady Gill. And this is O Chemistry, and it is a Christmas tree out of our blood top venipuncture tubes. So my daughter came up with O Chemistry, and I did rest. So
Oh, you're stealing the dad jokes from me.
Oh, gosh.
we are full of them over here. So all of those are available if you ever want to do your Christmas shopping, and season's already here. It is Halloween, so happy Halloween to everybody
Happy
watching.
Halloween.
And
And
I guess we're gonna go ahead and
Hey.
get started.
Tiffany,
Yes.
are you ready?
Are you ready for what?
Are you ready to celebrate?
Yes.
Oh, I am. Let's have a blast.
Let's have a blast. Catherine, you're sharp.
Catherine.
Yes.
Bam, blast.
All right, so let's make this happen. Woohoo. All right. It always takes a minute. All right, here we are. Can you all see very well?
Mhm.
Okay, excellent. So this week is week 4. Like we were talking about, it is the week that makes or breaks the team's progression into the playoffs. So this is the first week also that with international play, there is a prize awarded to someone randomly. So this is a random selection of who is getting the tumbler. All right, so we've got this beautiful tumbler. It does really keep your drinks warm and cool and everything. It's really awesome. It's double walled. And Carly Roberts in Kansas, it is already being made for you right now and on its way. So I ordered it last week, and so hopefully it will be there soon. So far, we have just had participation in the United States, but it is a global competition. So if you are able to beat my perfect score in less than 58.895 seconds, then please submit. I keep putting the link in the description of this video in each episode. So make sure that you're submitting, because we will be able to ship these presents to you anywhere. And we want to make sure everybody knows how awesome you are. So we did see a change this week in a lot of different stats here. And I'm going to tell you, I am super pumped.
Lots of shifts.
there's a lot of shifts. Left, right, up, down. We've been
Oh,
going
boy.
everywhere. Yes. And it is not due to immaturity either of white blood cells. This is a lot of craziness that's happening. And so it's made the possibility of who you thought was going to the playoffs kind of up in the air. So it is incumbent upon us to make sure that we also say that the trophy listed here unfortunately will not be the trophy that is presented to the winning team. We just really found that out not that long ago. But there is going to be a trophy.
It'll be a beautiful trophy though.
It will be gorgeous. It just happened to be that this whole thing kind of came about so quickly that we were not able to get this in production soon enough to make it so that the winning team had this trophy. However, there will be a special surprise that I'm going to try to make happen to make sure that this is going to be still something special, at least on this trophy. So more of that later.
More to come.
Ooh, mystery.
Ooh.
Okay, so Aaron, are you doing the West this week?
I can do the West. I
Can you do the
feel
West?
like you kind of like talking about the West a little bit.
Well, I don't want to get
You
too
like your dip
animated here.
talk. I can break down the West. So we've got
Oh, I'm
three great
sorry.
teams in the West.
I keep forgetting.
Weber State is hanging in there.
Hanging.
Still number one.
Well,
Their,
they
their
were
seconds
number.
went up a little bit though.
Yeah.
I don't think they're going to make the Lady Gill Challenge, but it's still an extremely impressive time.
Mhm.
UC Davis Health in Sacramento is holding on to number 2. And then actually Portland Community College in Oregon, they're still hanging on to number 3, and they're the only one in the group that had a time that went down 5.86 seconds. Still
So it seems like
extremely impressive times.
Seems like we're getting a little tired, maybe, all these weeks of being number 1. We were, you gave up that play this week.
It's an adrenaline game. Yeah, you got to keep going.
Yeah, it is tough. You do crash. So we'll see some beautiful faces from Weber shortly in our selfie section.
No leukemia. Got to keep
No
going.
leukemia. Catherine, I think you are really excited about the Midwest here.
Oh, absolutely am I excited about the Midwest. As a Wisconsin native, I am happy to say that Northeast Wisconsin Technical College held out at number 1 spot for this next week. Their time even went down by 2.4 seconds. And there's been a big shakeup in the top here for the Midwest. 4th spot, Houston Methodist Hospital Medical Laboratory Science was in 4th last week. They actually bumped their time up to be in 2nd this week, dropping 6.23 seconds. And University of Kansas Medical Center held strong at the 3rd spot.
Yeah. I don't know what happened with Southeast. I don't know why there isn't a number there. I think it was just because they weren't in the top 10.
Potentially.
But that doesn't make sense. I don't know. I don't know what I forgot to do there.
Yeah. UT's Health San Antonio unfortunately dropped down from the number 2 spot all the way back to number 5. Northern Illinois University, they came up from spot number 10 all the way up to number 6, taking 6.65 seconds off of their time this week. St. Paul College held on spot number 7, 34.94 seconds, as well as the North Kansas City Hospital School of Medical Laboratory Science. They kept spot number 8. University of Arkansas for Medical Laboratory Sciences, they actually came into the top 10. They were spot number 14, dropped into spot number 9 this week. They took off, I think, the most time out of any team this week of 8.37 seconds off their time. And St. Francis Health System School of Medical Laboratory Science, they fell back from spot number 5, but kept it in the top 10. Even though they took off time, there is a lot of improvement in the Midwest this week, and there is a big shakeup between all of them.
Absolutely. And we all know UAIMS out there. So great job, students out there, great faculty too. Yeah. So I did
get to
figure
join
out
them this spring.
yes.
Yeah.
Yes, and actually we do send our students there. We have an agreement with UAIMS and they do awesome work. So
Awesome.
they do have an online program and a face-to-face program. So if you are nowhere near their location, then you can absolutely join in, just like Catherine does with Rutgers, because it's awesome. I did figure out what happened with Nebraska. They didn't play last week, and that's why there's no number.
Okay.
So, yeah, that kind of threw me because it's been a few days since I looked at this, but sorry about that. So yes, I want to cover the East this week because I have some stuff to say.
Oh no,
You do.
not to say. Oh gosh.
There's a little bit of smack coming. So Southern West Virginia Community and Technical College, we are so proud of you this week. I mean, we're always proud of you, but this week you moved up from number 2 to number 1, and you brought the touchdown over to the East. So we are really extremely proud of that. And College of Southern Maryland, yeah, we made it into the top 2 for this week. We finally beat University of West Florida.
Oh. Yeah, it had to happen once, so you know.
At least once is good. Come on, be happy
for
me.
Reached out to Katie Carver and Mark Del Luna, and they're like, we'll let him have it this time.
Well, it was awesome. So College of Southern Maryland and West Virginia both beat the winner of all 3 weeks previous. So I'm very excited about that. We were the top 2 in the nation for that week. So oh, I thought Catherine was like looking to make sure I was right. And so West Florida did awesome still. They did bring down their seconds by 0.36 seconds, but that landed from number 1 to number 3 this week because College of Southern Maryland just decided to take over 5 seconds off. Yeah, we were going for it.
Their white cells are maturing at the right time. So it's all about the right level of maturity. Gotta have a balanced dip.
Going strong.
You gotta play it smart.
Oh boy.
You gotta go to the feathered edge and then come back a little bit and then back to the feathered edge.
Feathered edge makes you look wonky, right? You don't want to be out there. You want to be in the good area. So
gotta be in the good area of the slide.
University of Tennessee. So we had a little mix up before. They are coming over to the East now. And so last week they made it into the, I think the 8th position or the 9th position. It was the 9th position last week. You can see that on Twitter and the community, the MLT, sorry, wrong part, Medical Lab Lady Gill community tab. But they are making it, they were in the 9th, the top 10 last week in the East. And now they have gone up from number 9 to number 4. So they are doing.
It looks like I misspoke earlier. They actually took the most time off out of anybody. They took over 10 seconds off their total time this week.
Yeah, totally unexpected, right? But there is a lot of great work here because we've got UAIMS doing 8.37 seconds. We've got West Virginia doing like 5. CSM did 5.5, and then Tennessee is doing almost 11 seconds, and everybody below them too is pulling off some seconds too, a good amount as well. So it's been really crazy. You think you know where you're gonna be, and then you're just getting better, or somebody had this crazy amazing week. So Rhode Island has been holding strong. They were in number 6 last week, so they moved up 1. We've got a switch between them and UMass, right? It's been very, very close. I mean, this is ridiculously close. Up here, look how ridiculously close that is. It's 0.2 seconds. This is crazy. This is crazy. We are cutting hairs here, really. with just seconds. And then we've got AHN, St. Vincent School of MLS in Pennsylvania, and they have gone down just one, but their time went down as well. They're doing awesome. And we've got a switch between them and Central Piedmont in North Carolina. And then Mercy has made it onto the board again. Mercy has been,
Congratulations.
yes, great job. Mercy has been hanging tight with West Florida and CSM this whole time. I've been watching all of us because we've been like the three tight knit ones, and they are bringing it back. So way to go. And she's a friend of mine too. So is there anything you want to say to any of your friends out there, Aaron and Catherine, hanging in there in these groups?
Oh, I can go. Shout out to Marissa James at North Kansas City Hospital at their lab-based program. They've been hanging in the top 10 in the Midwest for a while.
Mm-hmm.
Excited to see Nathan Johnson's group at University of Kansas. Arkansas on the board.
Mm-hmm.
Yeah, UANs.
Yep.
So we've got Marissa on next week, actually. So she's going to be a co-host next week, our special guest from the bench. And so we can see her next week and tell her how much we've been cheering for her, right?
Mm-hmm.
Yeah.
Okay, so this week, since we are talking about the playoffs, this got so serious, right? We had to do 2 slides. We are not done, ladies and gentlemen. Everybody's wondering, who made it? Come on, just tell us who made it. I texted Aaron and Catherine, and Aaron's like, well, and I just laughed at him.
You have to wait like everybody else.
Yeah, I was so happy that, I was hoarding the information. I was so excited. I did want to tell everybody.
I was on the edge of my bench. Yeah, it was just crazy.
It was hard to keep it in, let me tell you.
Mm-hmm.
So let's take a look at what we've got going on here. We've got in the West.
Whoa.
So usually we're used to seeing the program team highlighted being the touchdown for the week. These are the teams that are going to week 5 and making it into the playoffs. Okay. So do you want to keep going, Aaron, with the West, or you're muted? Sorry.
My bad. So for the West, Weber State University, the Wildcats,
woo,
finishing on top, going into the playoffs. UC Davis, the Aggies are going in. Number 2, it's a clear slate as you're going into the playoffs. So this could shake up things.
Mm-hmm.
Absolutely.
Definitely.
Yep.
That's a good point, because we have been doing the average of every single play during the first 4 weeks. And as Aaron was saying, it really is a clean slate. You come into the playoffs, what you've done in the past means nothing anymore.
Mm-hmm.
It's all in the play that you do that week. So good luck, everybody.
It is a brand new diff.
Oh, yeah.
Brand new diff.
Aaron, you warned me about the hematology dad jokes, and I don't know if I was expecting them to be this great.
They are here.
They're very strong. They're very strong.
They are here.
Oh, yeah. Okay. In the Midwest, the 2 teams that are moving on to the playoffs are going to be Northeastern Wisconsin Technical College, the Eagles, and the University of Kansas Medical Center Jayhawks. Woohoo!
We have a friend, Dana, who is a Jayhawk lover too, right? She works there.
So she is our new chair of the Laboratory Council Professionals.
Yep, taking over for Aaron and the great job he's been doing, supporting the Cell Bowl a lot. So thank you very, very much. And hopefully we can have the same partnership with Dana.
Definitely.
Yeah, she's awesome. Keep on going, Catherine. I'm sorry, I got really excited.
Oh, no, totally. I'm just excited that there's a team from Wisconsin that's moving on to the playoffs. Wisconsin is known for its great football with the Packers. I'm excited that we're doing just as well in the Midwest for the Cell Bowl. Go Eagles. I'm rooting for you the entire way.
And it's so weird because over here in Maryland, the Eagles are a football team. And so are you going to be doing the chanting of EAGLES?
Oh God, I don't know if I'll go that far, but I'll definitely be excited and following up with them and making sure that they're doing good. So
Oh, not in Maryland. Sorry, that's Philly. But I'm like every time, yeah, you can spell. I actually went to school near Philly, so I'm okay.
Okay,
I'm not
I
gonna
was
give
about to
you
say,
But that's
got
why I
family
was
in
like,
Philly.
I don't know why I said Maryland. I'm so sorry, Philadelphia. I love you. But it just feels like home too, because I'm so used to them. But I was thinking of the Ravens for some reason.
Yeah.
All right. So we had a UT Health San Antonio guy on last week. And so I'm sure that he's watching this cheering and shouting at the computer to like, yeah, UT Health. We were cheering for you last week as well. That does not mean that anybody else in this line did a terrible job at all.
No, not at all.
Yeah,
No,
you've got all these perfect scores.
it was so close.
Everybody's making perfect scores. This is incredible. So it really, when I was doing the averages for the 4 weeks, it all came down to times. Okay, so next week I am going to post the national standings. It only goes up to the 25th place setting. I'm not doing all 73. Okay. Woo. So we're only going up to 25. And I am so excited to say that the College of Southern Maryland is number 7. Wow! All right. I just had to get that in there.
We were waiting for that too.
Yeah,
I have been holding my breath. We are number 7. I am so excited. We missed. I am so frustrated about this because we were so close. We were 0.5 seconds away from getting in there instead of West Florida. Sorry, guys.
Oh,
Yeah, so close,
oh.
so close. But we are very happy that we've got, I've got 2 places that feel like home to me as well. West Virginia and Florida going into the playoffs. So bring it home to the East, guys. We want to happen. We want to make it happen. We want to be the first winners of the first ever Cell Bowl. We are making history, you all. And so being in the playoffs is incredible alone. And to bring home that trophy. Oh my goodness. I mean,
Congratulations, Katie Carver and Mark Del Luna and Dr. Bahan at West Florida. Very proud.
Absolutely. And, Catherine, we love you, but, you're Midwest.
Yes.
We're gonna bring it home. We're gonna do it.
Oh,
we're gonna do it.
Maybe top 2. I'm okay with you being top 2.
We don't settle for second best here. We're going all the way.
Well, so you heard it here, everybody. Make your bets. Do them privately. We're not hosting that on the show, but be really excited. I think I'm going to stick a poll out on social media to see who we have rooting for whom. And so let's get out there and cheer these teams on. I am so happy that we can have the support of ASCP this year. I've been trying to get this into fruition for a couple of years now, but this year it was something that actually happened. So I am so excited that we are able to make it here. But I wasn't kidding when I said Mercer and CSM and University of West Florida were so close. Look at this. Our averages were only a couple seconds apart.
It's
This is
crazy.
crazy.
Yeah,
So
great job, everybody.
and bowling was leading us for a while and they dropped down just a little bit. I mean, it's just seconds. This is ridiculous how close all of this is. So looking here, we've got the theoretical trophy here right now. And we've got what was submitted for the logos. So Weber and Kansas, we've got UC Davis, and we've got Northeast, Southern West Virginia Community and Technical College, and then we got University of West Florida. So these are the teams you are looking at. Make sure you are rooting and supporting socially everywhere. tell everybody about it, tell everybody where you landed, get it out there. As Catherine was saying, we really want some visibility of the laboratory, and it's very important to share with the world what we do. So yay, we're doing a great job.
Hey.
Great job, everybody. Even if
Good
you didn't
job.
make it to the playoffs, we are so proud of you.
Yeah,
And
absolutely.
keep playing from the sidelines too.
Yeah,
Oh, yeah.
absolutely.
Cheer team's on, but keep on playing.
We've got individual play still happening. You can still win lab swag, right? Hematology
Oh, yeah.
Hero lab swag. I keep putting the fanny pack up. There's a whole bunch of things that you can do. I've heard from program directors that they're going to still keep on going even if they're in the playoff, if they're not in the playoffs, and they're going to be playing in-house. I know my program is going to be doing that. We do it every semester anyway. But you'll see our trophy, our real trophy that we have just for our program in a couple of slides. But absolutely. And program directors, all these prizes that I'm giving out for the international, they're available in the store also. And I have had some contact from people asking where can they get them. It's in the store, that Medical Lab Lady Gill store. All right, so we are now at the educational, we're calming down a lot more, educational session of this episode. Zooming in again. And Catherine is our resident expert here, hematologist from the bench. So could you tell us a little bit about the structure and function of the granulocytes that we're focusing on this week?
Of course. So the first granulocyte that we're going to focus on right now is basophils. So basophils are named actually after their types of granules. So their granules take up the basophilic or the basic part of the stain. So that's why they're called basophils. They have a bilobed nucleus with clear cytoplasm, and they have those large, deep blue granules that contain acidic contents. A caveat from the bench that I will mention is that these granules, they don't take up the stain super well. If you overwash your slides, you can wash off the stain from your basophil granules. They can look a little washed out on occasion, but those large granules are very characteristic of basophils. They help regulate our helper T cells in the immune system by releasing cytokines, and they cause B cells to make IgE, and they're also known for angiogenesis as well.
That was something new that I learned, the angiogenesis part. That was really cool.
So next section on eosinophils. Eosinophils are my personal favorite. I love Eos. That's it. You'll hear us shorten the slang for the cells. So we don't call them basophils. We don't call them eosinophils. They're Eos and Basos. Just so that way it's just easier and quicker to say on the bench. Eosinophils are like basophils where they have a bilobed nucleus, clear cytoplasm. However, they have red-orange secondary granules present that contain basic proteins. So they're named eosinophils because they take up the acidic or the eosin part of our Wright-Giemsa stain mixture there, our Romanowski stain. Eosinophils have a primary function in inflammatory response, and they're also immune mediators such as antigen-presenting cells, and they secrete cytokines. Patients will have increased eosinophils if they have really bad allergies. So they're really, really present in allergic reactions. I know that there's a TV ad for eosinophilic asthma. If you've heard from it there, it's because of the increased eosinophils in the lungs. They're also very prominent in parasitic infections.
Exactly.
They help fight parasites. We always used to make fun of one of our teachers at school because she would always caveat her statements. Because when we were doing our learning at my undergrad at UW Oshkosh, our instructors and our professors would have their blood drawn for our mystery slides for the final.
Oh, cool.
And well, we had mystery blood for the final so we can do all of our counts and everything. And we would always joke, we knew we had her blood because she had really bad allergies. So she had a high eosinophil count, but everybody always joked that she had a worm. So even though we knew she didn't, everybody would always joke because she would say, she's like, I don't have a worm, I just have allergies.
Oh my
So, so
Anytime she coughs, you're like strongyloides.
Oh, no. Start chewing. Ew.
Okay, and the last and the most prominent of the granulocytes, after I just completely go off on a tangent about eosinophils here.
Oh, we do.
Yes, just a little bit.
Yeah, the most common granulocyte is going to be our neutrophil. So the neutrophil contains 2 to 5 lobes on its nucleus. It has pink granular cytoplasm containing acidic and basic components. So that's why it stains that pink color. I like to say that, you know, basophils and eosinophils, their granules look super chunky. Yeah. Neutrophils, they're really, 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 really sandy. Mm-hmm. So there's a key difference in figuring out, is it an EO? Is it a neutrophil? Is it sandy? My cat's starting to cough over here and I can hear her. So come on, kid.
So when we're talking sandy, we're meaning really fine granular and not
really fine granules.
Not as like, if you see, there's the here's the difference. You got these huge granules even on the band of the eosinophil here. You can see that, and then looking at the neutrophil, you can hardly see them at all. They're kind of like little dots. Yeah,
they're very, very sandy. So neutrophils are part of your innate immune system. So have we done lymphocytes yet, or are lymphocytes coming up? As I say, you'll learn about lymphocytes. Those are your adaptive immunity, so your innate immunity. So this is chemotaxis and phagocytosis. They protect against foreign invaders, particularly types of bacteria, and they help with absorption of vitamin B12.
Absolutely. So that was really well done. I'm so happy that you said it the way that you did, because we have been trying to keep taking it back to the first episode when we were talking about the stain and why do cells look that way on the smear. So it's really good that you were doing that. You picked up on everything. It was awesome. I loved it. So when we talk about why are we producing these cells to begin with, it's because we've got some type of challenge to the immune system. There's some type of cytokine that's signaling these differentiations. So we all start out with a pluripotent cell, and the more that you get further down the chain, you start to differentiate into basically excuse me, pairs of cells that may come from a similar pluripotent stem cell. So depending on what your cytokines are that are signaling that differentiation, you're going to end up with whatever at the end. Okay, and so these are true white blood cells because they are developing within the bone marrow, and then you should be seeing mature cells in the peripheral blood smear. However, there is always, as Catherine was saying, there's always a caveat. So just like in red blood cells, if you have a challenge on your body that there needs to be a heightened reaction to, or something's wrong with the bone marrow, as Carlo was saying in week 2, you're going to end up seeing possibly less mature cells. And so when we're looking at these pictures in this chart, we're looking at normal, healthy adult maturation. We're not talking about those conditions where you see those blasts and everything in your peripheral blood smear due to some type of condition, which we are going to talk about. And Catherine's going to have an awesome time with it because this is her specialty. This is what she loves. So we're really excited that she's here. So here on the automated CBC, you've got what we were talking about before, where the cells are counted in single file line. The size and internal complexity are going to be analyzed. And so when we talk about those big chunky granules versus those fine granules, we're looking at the instrument knowing that because of how it's blocking either light or, making light scatter, or if it's blocking the blocking electric voltage, current
Mhm.
as it's going through. So size and internal complexity are going to be measured by those. We've got the breakdown of the automated differential. So differential is just telling us how many of the different types of white blood cells we have. So if we have an elevated white blood cell count, looking at that automated differential is going to tell you what type of condition you're possibly going to be seeing.
Mhm.
And as we've talked about before, you can have it where there are false elevations, okay? And we talked about platelets last week causing those false elevations possibly. That second week, we talked about nucleated red cells, although I hadn't put them on here. And then how do you go about looking at the smear, the peripheral blood smear, and seeing if it really does match that automated CBC. So there are different things that you can do on the smear review. You're obviously looking always at the red blood cells to identify if there's anything weird going on there, as well as checking out those platelets, seeing if they're in the normal size and amount, if they look okay. And then you're moving into the white blood cells here with, all right, does the count seem like it's matching? Are the types that are represented in the automated there as well? And if you notice, the basophils and the eosinophils are not considered ones that are in high amount, as Catherine was saying. It's mainly those neutrophils. But if we are in a condition, as she was saying about her educator previously, those can rise. And when those rise, you can say, oh, well, that elevated white blood cell count is because of an elevation here. And that must mean, you know, we have this kind of condition because of what type of white blood cell it is. So it's very good to know what they do in the body, because if you don't know what they do, then these results aren't really going to mean squat to you, right?
Yeah.
So here we've got pictures of what the maturation stages are with these cells. And so at the beginning, when they're pluripotent, they look very similar. So we've got the myelocyte here. So that's the third one in maturation. So myeloblast is on the left. It's going to have the highest end to C ratio. All right, if you see it, you know, you can see those nucleoli right there as well. Almost looks like two eyes looking like a face. They are pretty large. This is from the peripheral blood smear, and this is from the 5th edition of Rodak's hematology textbook online. So you might be able to see this there. And then you've got the next stage is the promyelocyte. So you can see how there's indentation now of that nucleus. You've still got the nucleoli there. The cytoplasm is changing. Okay, it's becoming a little bit more present there. And the color is a little bit different as well. It's not as deep. And then we're moving into the myelocyte. The nucleus again is getting smaller because your chromatin is condensing. And again, the cytoplasm is changing as well. And as we're going through, you're going to notice that you end up having more cytoplasm than you do of nucleus. And so these are the normal maturation stages. And when we get to talk about the conditions like what's on the right, Catherine's going to be talking about those. The main thing that you want to notice is the normal maturation happens in the bone marrow. So if you see an immature cell in the peripheral blood smear, if it's part of the leukemias, it's not necessarily going to follow the same type of maturation as in the bone marrow, because the cytoplasm and the nucleus are off kilter. They're not developing at the same rate as they would have in the peripheral blood. So she's going to spend a lot of time talking about that.
I'll actually chime in here, because this is actually one of the big sections that even as experienced techs, we struggle with, because as I'll say going forward, hematology is a gray zone. Not every single cell is going to look picture perfect. You will never have that picture perfect moment where every single cell in your diff looks like what it's supposed to.
Yeah.
What I always tell my trainees when I'm training someone and having to do diffs, we teach them the 3 Bs. If it's big and blue, it's usually bad. We don't like seeing big basophilic cells in the peripheral blood. So that myeloblast in there already raises red flags because it's a very large cell when you're comparing it to those red cells right next to it. It's very basophilic. So it's not, we don't want to see a lot of basophilia unless it's a basophil and it's the granules. If the cytoplasm is basophilic, it's raising red flags. There's usually not anything good happening. Your promyelocytes, we will not generally see those in high concentrations in peripheral blood, if ever, outside of chronic myelogenous leukemias or CML. Even in CMLs, we see them at maybe 1 to 2%. Unless you have a promyelocytic leukemia, which they won't look like that picture, they'll look very different. It's very uncommon to see them. And for myelocytes, we get a lot of people who get tripped up with myelocytes. Don't feel bad about getting tripped up with myelocytes. Even experienced techs have problems. What I always like to tell my trainees, because some people confuse like a pro, like, is it a pro? Is it a myelo? Pros will never have pink granules. Never, ever, ever will they have pink granules. Pink granules are only present with cells that are myelocyte or more mature. So the moment you start seeing pink in your cytoplasm, you are done with being a pro. You are going to be a myelo.
So we have that listed here. So we got pros being basophilic, and then myelo, you get the pink. All right. And it's also the last mitotic stage, if you're into that. So if we're looking over here, Catherine, are these promyelocytes?
No.
What are they?
If we're looking at that one,
sorry.
I just say if we're looking at that one, if
This one on the right.
Okay. So we're looking at the one all the way on the right. That for sure for me is a blast.
Yep.
Because I'm seeing nucleoli. It's got a very high NC ratio. It's the largest cell in that image, and it's got basophilic cytoplasm. I'm immediately concerned when I see that cell. The other two,
okay.
That one I might say is a meta. I wish I had a microscope where I can focus up and down and change my light to where I could tell for sure. And same with the bottom one, I could be convinced either way for a meta or a lymphocyte. But that one's getting down pretty small. The nucleus is about the size of the red cell. I'm not convinced that it's something malignant at this point because the chromatin is getting chunky. I can see the condensation of that chromatin.
So what did you say again about the middle one? The door's open, guys.
It's okay. I think it could possibly be a meta because it's got that kidney bean shaped nucleus. The cytoplasm color is a little bit blue to me, but I can't rule out there being any pink in it. So because I can't rule the pink out, we always lean more mature. So we never want to lean immature in teaching cells because if you're leaning immature, you're going to way overcall your immature cells.
Right.
I don't want you to have to convince me that it's a mature meta. I want you to convince me that it's a blast. I should be immediately thinking a more mature cell type.
Okay, thank you. So we've got some, this is a neutrophil metamyelocyte here. I couldn't find the basophil and the eosinophilic metamyelocytes, so sorry. And it
Totally
made
fine.
it,
They're not common.
it made it so that the chart was able to fit too. So this was great because we're covering 3 different kinds of cells, and that would just have been massive. So looking here, we've got the granules and each of these changing as well. So we've got, we started off with our coarse granules in the myelocytic stage, the myelocyte stage, and then the metamyelocyte stage, we've got them continuing to be there, but then we've got secretory vesicles being produced and tertiary granules for those neutrophils. And then when we get to the bands, you're looking more at the nucleus here of not seeing a filament yet. You're seeing this kind of like a, I don't really want to say barbell, but I kind of do, just because it's got that thick center in the middle there.
Yeah.
And I can't zoom in anymore, and I wish I could. But you can see here, it's kind of this reddish, pinky purple type of nucleus, but there is a slight indentation, but it's still thick. All right, so you've got these little dumbbell areas on the ends, but this thick area. This one you can see better in the band neutrophil. It's this horseshoe shape, but you still got that thick, that thick center there. And as we're going through, they're getting a little bit smaller than what they were, but they're going to stay about the same size after.
Yeah. And that picture shows a really good point for the eosinophils and the basophils. The granules will have no problem sitting on top of that nucleus.
Oh yeah.
So they will obscure the nucleus if you're not careful. And maybe this is just a difference in teaching. I think everybody teaches bands and full mature segmented cells differently. For me, for both of those, I would not call those bands because it's not completely smooth and a uniform width the entire length of the nucleus. But I'm also very, very picky about my bands. I know some people are like, oh, if I can't see the filament, I'll call it a band. And again, it's for a lot of people, it's a personal preference. Everybody teaches just a little bit differently. For us, we teach that it has to be a completely uniform width across the entire nucleus for it to be a band, because if you run into the old school doctors, they actually use band counts about infections, which we're trying to stray away from that. We don't want people to be using band counts. But if you're starting to overcall your bands, you're going to start freaking someone out on the other side, because they're going to think their patient has an infection when really you're just undercalling the neutrophils. So it all depends on where you get taught how to do your differentials as to how you call your how you call those nuclei. So whether or not it's a completely uniform width, like we teach at our hospital, or if it's just no filaments.
So it's just tough, and it's with anything in lab science, it's just practice and seeing it, and it's an art form.
It is an art.
It really is institutional policies too, because like you said, it varies depending where you go. Even in your book, you're going to see a varying, whichever book you go to, a varying decision-making set. And I think in RODAC, it talks about different ones, and it does talk about what we're talking about right now. You're either adding them into your neutrophils, or you might call a couple of them or some of them, but you're really putting them into the neutrophil category. Is there really a diagnostic change in calling more bands, or no?
I guess that depends on your provider. We've had recently, we actually had an issue. We're trying to take at our hospital some orders out of the physician's hands, because as laboratory professionals, we know it's going to be more accurate. And we have a provider currently who's upset that we took the manual differential order away from her, because she wants to order manual diffs because she uses the band to neutrophil ratio for some kind of a prognostic factor. I'm not 100% certain what it is. But we had to explain our analyzers are very good and count way more cells than what I as a person will. I only count 100 cell differential. If the patient has an extremely elevated white count, the analyzer will count way more cells than I ever could. It counts thousands of cells when it does its differential. And as we talk about it, and we mentioned it for the automated, we build rules in our analyzers. So that way, then if something is abnormal on the scattergrams that the flow cytometer produces, because a lot of new analyzers nowadays include a flow cytometer. So we'll build the rules. And if it flags for us, 3%, whatever it puts into immature granulocytes, so bands, metas, mylos, if it counts anything more than 3%, we manually diff it to make sure that it's accurate. If the neutrophil area in our scattergram is just shifted slightly to where it's left shifted and it could be bands, it flags and says, we think that there's a left shift present, do a manual diff. So the analyzers are very smart, but again, it's all based, it always defaults down to the tech to make sure that we're calling stuff accurately.
Absolutely. So that means you'll never be lacking for a job as a laboratorian, because even though we have laboratorians that go on to make these analyzers a lot of times, it doesn't mean that the analyzer can replace a person who is able to distinguish between these different nuances and know exactly what they mean.
Well, and they'll probably talk about lymphocyte maturation further on, but lymphoblasts can be very tricky. We have had patients where their lymphoblasts are very small and they gate with the lymphocytes, and we've missed ALLs because the analyzer thinks it's normal. And thankfully we gave our doctors an orderable where if they think that it's like an ALL, they can order a smear review where we physically have to look at a slide. We can send the auto diff out, but we physically have to review the slide to make sure that there's nothing abnormal present. So that's something that we created as a fail-safe. So that way, then if someone is concerned about something, they can order this smear review and say, concerned for this. So we double check and we look for it.
Yep.
And you can always put notes into the LIS so that anybody who is being called about a certain situation, they can always see what it was that someone was looking at. Do you all save your slides at all?
We do. So we are a CAP accredited laboratory. CAP accreditation requires slides need to be saved for 2 weeks. We actually save our slides for 2 months because of situations, like this, where, we may have missed something, so we can go back and look at previous slides. And it's happened where a doctor will call our hematopathologists like a month after something and be like, hey, can you look at this slide? And we can go, yeah, we still have it. Don't you worry about that. So we keep our slides extra long just to be safe, but you aren't required to keep them that long. They only have to be kept for 2 weeks. But for our complex hospital system, we keep them longer.
Are you all looking at going towards an automated visualization type of
Like
analyzer?
television?
Yeah.
We have Celavision. We actually have 3.
So you're saying that as the manual?
No. So we have rules in place at our laboratories to prevent us from missing critical diagnoses. So like I said, our analyzer has rules. If our analyzer has a flag that says blast abnormal lymph ? Because something gates into a weird spot between the monos and the lymphs or is really high up on our scattergrams, we have to manually look at the slide because any big cell will get pushed out to the feathered edge and the edges of your smear because it's really big. It just keeps moving. And Celavision does not take pictures of that area. So we physically have to look at those slides. If we are on Celavision and we see a blast, stop diffing on Celavision, you manually diff it at the microscope. Anything that could be clinically significant, we have to do manually at the scope. But we do 3,000 CBCs a day. So we are a very high volume laboratory, and being able to do a bulk of our differentials on an automated platform like Celavision really helps, because then we can easily reclassify stuff and send it on its way without really, being slowed down as much as having to manually count a differential.
And you both make really great points of the fact that as students, there are going to be instrumentation rules, there will be policies and procedures in place. You're also going to have other laboratory professionals there for you, so you're not alone. So it's great that you guys have kind of also showcased all the different things that are in place to kind of help you. And you have the team itself, like you can put those notes in, you can talk to the team. So
there's
cool.
no shortage of conversation in our laboratory. You'll see someone will be like, hey, Katie, can you come over here? I need you to look at this cell for me. We have those conversations all the time. It's not like, it depends on the size of your laboratory. If you're in a very small lab and potentially you are the only tech on shift for the entire time, then it gets a little trickier. But there are physical resources that you have where you can look and review and compare slides. But if you have a big enough team where you have multiple people in the department, you can ask someone, hey, can you come over and look at this? I just want a second set of eyes on it. So that way then we are conferring with each other to make sure that we're making the right call.
Yeah, we have, so I came from a very large hospital. I came from a small hospital and a very large hospital lab. And we would be in the large hospital, we would be on another bench and somebody had something, hey, and gather everyone that's trained. Oh yeah.
All the time.
Oh yeah. Everyone that's trained comes over, takes a look. What do you think? And there's like there's a polling of everybody.
we poll people. If we see something super rare, like I said, we're in the Midwest, we're in Milwaukee. We don't see a lot of parasite cases.
Oh yeah.
But we had a really nice case of Plasmodium falciparum come through our eDoors a couple of years ago. We made a bunch of slides. Our hematopathologist just an extra half a tray of slides for saving for teaching purposes. But we made a bunch of extras for us. And that teaching scope was a hub of activity for 2 days because we want everybody. It's like, hey, did you see the case of Plasmodium?
Oh yeah.
And everybody comes over to look at the scope so they can see it and
see all those rings. And if you're lucky, you get the banana gametocyte and
it was only ring forms, unfortunately, but it was it was a 20% parasitemia. So patient survived. But yes, no, we hadn't seen one that high in years. I still have the extra slides because I actually take an extra set to the high schools and I show them that one. So
nice.
That's really awesome. Is there anything that you wanted to say in particular about here before we moved on a little bit more to conditions?
No, not at all.
Okay.
I think for normal stuff, this covers it.
Yeah. We've got just one last area, and we kind of talked a little bit about it already. And I bet you that when somebody watches this, that they can't see where it is that we're looking because our faces end up getting in the way. But do you want to talk a little bit about this distinction between conditions, quantitative and qualitative disorders with granulocytes affected?
Sure. The big ones that I can think of as far as quantitative disorders are the acute leukemias. So that typically presents as an increased production for white cells, and they're increased in immature white cells. So there's something that happens in the bone marrow where one cell that has a problematic gene does not get destroyed when it should. And it just starts proliferating and taking over and overrunning the bone marrow. And then eventually it will spill over into the peripheral blood. And that's when we start detecting it. For patients who have acute leukemias, one of the most common things that we hear them talk about, the fatigue, night sweats is a common symptom, but bone pain, because the bad cells are packing into the bone marrow. So it starts making their bones hurt from the inside out. And I know you wanted me to mention it. You might mention it better about the different classifications of types of leukemias, because I think that's a big thing that confuses people now.
Are you talking about the question I was going to ask you?
Potentially.
Okay.
If you want to bring it in there, because unless someone tells me specifically what the disorder is, usually it's been 6 years since I've been in school, guys. We don't talk about specifically the quantitative or qualitative disorders. The person you should really ask that of is your week 7 host.
Yeah.
He's great at going over stuff like that. It's more or less, we'll see stuff at the bench that we just know is problematic and have to forward along, or different conditions. Like we mentioned B12 earlier and folate deficiencies. If you have B12 or folate deficiencies, you will get macrocytosis, which I know is mentioned most likely during the RBC. You will also get hypersegmentation or increased segmentation of the neutrophils. So instead of the 2 to 5 lobules that are normal, we call anything with 6 or more hypersegmented. And we actually, if our policy is if you see one hypersegmented neutrophil, you call hypersegmentation in our laboratory, but that's just our lab's policy. There can also be hyposegmentation. So the neutrophils, not the neutrophils, the basophils and the eosinophils are commonly bilobed. There's only 2. And neutrophils are more than 2. If you're getting cells that just have 2 lobes or are arrested in the band stage or have really dark condensed clumpy chromatin, but have the shape of a myelo where they're that nice round nucleus, but the cytoplasm is super mature where it looks like the neutrophil, then that can be caused by a myelodysplastic syndrome, which is again a type of white blood cell disorder. Patients who are on immunosuppressive drugs for transplants usually have a lot of hyposegmentation because they're dampening down the immune system to prevent the transplant rejection. So that's unfortunately hampering the maturity of the neutrophils. So you see those there.
Since you're, I guess that's a good segue. Since you're talking about the maturation of the cells, when we're talking about looking at a, I mean, we already covered the AML here, but when we're talking about looking at the maturation on a peripheral blood smear and noticing the chromatin and the cytoplasm and looking for any nucleoli and, you know, what's the end-to-C ratio, all of those sort of things. Is there a way that you can look at the cellular morphology and distinguish whether it is a certain type of genetic mutation or translocation of genes that would cause the leukemia to begin with? Because I mean, we have the FAB and the WHO that we're used to seeing. And that was a very visual oriented, like what you would see on the peripheral blood smear. Now we've moved to genetics and using the mutations name, you know, we name them, there's a translocation from whatever to what. And now it's where students are like, well, I don't know what it is just by looking at it unless I go with the FAB. So what is your advice to students or new trainees on how to identify when you're seeing something in that look or that type and when to send it to get genetic testing?
Yeah, so the WHO, the new segmentations based off of genetic abnormalities is mainly because of the increase in targetable mutations for treatment. And this has come, you know, with the knowledge, because back in the day when the FAB was started for differentiating different leukemias, everything was treated the same. It was treated with this regimen called 7+3. So it's 7 days of daunorubicin and 3 days of a different chemotherapy agent. And that was how all acute leukemias were treated. And then all of a sudden it's just like, oh, you know, these leukemias are a little bit different. And that's when, you know, treatment for promyelocytic leukemias, PMLs, started with the treatment with, what is it called? There's a specific treatment for PMLs that uses arsenic. It's an ATRA treatment, which includes an arsenic regimen, which is actually really, 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 really good at treating APLs. And if you get treated, and if your APL gets treated with ATRA and you don't have other complicating factors, it actually has the highest survival rate. It has like an 80% chance of being in permanent remission just with ATRA therapy. So learning to differentiate them by visuals helped us kind of start, targeting treatments a little more. And then we started with the human genome sequencing. And all of a sudden now we can sequence these folks with AML and are like, oh, this mutation here caused this patient's AML. Let's create a drug to treat that mutation. And that's how we started, getting BCR-ABL and IDH1/2, NPM1, because now these drugs target a mutation in a gene that caused the dysfunction to stop the cells from maturing. There's not a great way of looking at a slide and saying, this is this molecular mutation. It's very, very difficult to do that. APLs usually have translocation 1517, the PML-RARA translocation, which that's what the ATRA treats, is it treats that translocation to get that to stop. And that's one where you can look at the slide and say, this is an APL. And that's one of the...
Just for the students listening, can you say what APL stands for?
Acute promyelocytic leukemia. So
thank you. I just don't want us to lose our audience.
I thought I mentioned what APL.
You did.
I think I said PML and then I changed it to APL.
You mentioned a lot. And I think, whenever you go over this in class, they glaze over. So if you don't keep reminding them what it stands for, they're like, what is she talking about?
Yeah. And that's one of the big things that, we train our new techs on. You have to be able to look at a slide and see an APL. APLs are very characteristic. They have those clumps of granules condensing into hour rods. There can be multiple clumps of hour rods. We always like calling the nucleus, because some people call it the butterfly nucleus, where it has two bilobes and they're either right next to each other, or sliding plates where they overlap each other. So we teach people how to look at the slide and be like, oh, these are sliding plates, or I can see the outer rods. Or so that way then it's just like, okay, APL, I got this. And then then we send it along to hematopathology, and if it's an off shift and we call the resident, I always tell people, if you think it's an APL, tell the resident you think it's an APL.
Oh yeah.
Because, if someone gets a phone call at 2 a.m., they might be like, okay, they see a blast, maybe I can come in the morning. The moment I tell the resident, I think I have an acute promyelocytic leukemia, they will get their butts out of bed and come in to look at it, because that is a hematologic emergency.
Yeah.
Not that other AMLs aren't hematologic emergencies, but specifically APL is a hematologic emergency for hemoncologists. And then after that, it's just like, okay, do you know the different FAB classifications? We teach them how to tell the monocytics apart from the APLs, from just the regular myelocytics. So like just the regular AMLs, like what's on the screen. We don't have them focus on different genetic mutations. The one thing that I was taught by one of our hematopathologists is that you can tell actually if a patient has an NPM1 mutation based off of the way the nucleus looks. The nucleus in someone who has a NPM1 mutation will look like a little cup. So it'll have a nice round bottom to it. And then at the top will be a nucleoli. So it'll look like there's the top of a cup in your nucleus. And it's like, okay, there's a cup-shaped nucleus here. I think this might be an NPM1 mutation. And we changed our ordering practices at our hospital again to try and take away some of the over ordering, is that now when we have new acute leukemics come in, instead of the doctors ordering every single mutation possible, CKIT, CEBPA, which I don't know the name of actually, I just know the acronym, FLT3, NPM1, IDH1/2, they would order 10 different genetic tests. And, that costs a lot of money.
Yeah.
So, and 95% of the time, all of these tests would come back negative. So there's a couple grand wasted there on negative tests. So we have our providers order what we call an acute leukemia panel. And they have to call us and they say, we're starting the acute leukemia algorithm, we're going to order the panel. And that on a bone marrow includes one tube for what we call an extraction and storage. So our micromolecular department is great. They will extract the DNA and RNA out of the cells and then freeze it in a -80 freezer. So that way then we can send it out if needed. And then we have 3 tubes that are good for 48 hours immediately to send out to other sites for other molecular tests if needed. So that gives us a bunch of material to work with if we need to send it out. Traditionally, the pathologists, if they can't visually see the mutation, they will send out for what's called a myeloid malignancy next generation sequencing or NGS panel, which covers IDH1 and 2, FLT3, NPM1, and all those big genetic mutations that have history of causing AMLs and have targetable treatments, and send that out. And that'll take about 2 to 3 weeks to come back, which during that time, they will start the patient on a 7+3 regimen. Unless it's an APL, then it's ATRA. But they'll start them on that regimen. And then if it comes back and, oh, the patient has FLT3 mutation, then they can add another drug to that treatment to treat the mutation. Or like, oh, BCR-ABL is positive, they can get treated with this drug to treat the BCR-ABL, and they don't need as intensive of a chemo regimen after we get them into that first remission.
So when in the treatment cycles are you ending up using the stem cells to try to replace the cells that are taking over the bone marrow? Is that always the case? Is that sometimes the case? Is it half and half? It really depends on what's happening with the patient. How do you know?
So that depends, and this is a good question for week 7 host Papa Heem, because that's his realm. But for us, it depends on the treatment goals of the patient. So if the patient is able to withstand a hematopoietic stem cell transplant, because that is very, very intense chemotherapy. The initial chemotherapy regimen, it's not something to be snuffed at, but it's just meant to push everything back and get the malignant cells, or the blast population, down to a point where we've killed off all the cells that are growing really fast. We think we got rid of the AML. Your bone marrow can recover. And the treatment for the stem cell transplant is you're wiping everything out. You're going down to nil.
Right.
So that it's very intensive chemotherapy prior to the transplant. Some patients, if they have a specific mutation like BCR-ABL in CMLs, they don't have to necessarily have a transplant. If you give them the drug for the BCR-ABL mutation and they take it and their counts go back down to where they're supposed to be, you can keep them on that drug for a very long period of time. And one of the people actually at my hospital is actually trialing, okay, we know this drug works really good for treating patients with BCR-ABL mutations in CML. They've been on this drug for a while. Let's trial taking them off of it to improve their quality of life.
Right.
And see how well the treatment holds out post stopping it. And I don't know how far he's gotten in that trial. I've just heard about it through our medical college's promotion of that project. But they might not need a transplant. Some patients who have APL never go on to transplant because the ATRA therapy treats them so well. If like I heard from one of my friends, it's an unfortunate story, but one of my friends, who was actually in my CLS cohort with me during our internship year, her husband unfortunately was diagnosed with AML, and the initial 7+3 regimen, which even though it's 7 days plus, 7 days of the treatment, you're in the hospital for a full 5 weeks after that first treatment. After that, and then what they call consolidation therapy, which is a lower dose of chemotherapy to kind of stick the remission. If after that, if you have 2 consecutive, I do believe, negative bone marrows and your remission lasts, they might never have to go on to transplant. It all depends on the aggression of the disease and the patient preference. If the patient's preference is to never go on to transplant, we have to respect that.
Absolutely. Well, thank you. Sorry, go ahead.
Oh, no, I just, Catherine made great points just as far as the way her lab works, that just for the students, that there's lots of pre-analytical considerations as far as having the right specimens, her micromolecular group prepping things correctly, that you can have the right test groups for physicians to actually direct them. So it's not only you on the bench making the diagnosis, it's actually helping them to order the right tests to get the right diagnosis. So that was, you guys made great points with that, so I just wanted to mention that.
So I want to thank you, Catherine. You've done a lot of really great education with us today, and made really great points, as Erin was saying. I'm just showing my references here for the poster. I was telling them off camera, the pictures that are not cited are from me, so that's why they don't have a reference with them. We're moving on to the selfies for the week. This is the first time we've had so much participation with the selfies, and I honestly thought I had saved the UAIMS picture on here, and I accidentally didn't save before I closed out the last time, and we caught it right before we started recording. So UAIMS was the gentleman here last week, and his picture was in again, so please don't forget that he's in the one that we're in now. So moving on to who's represented, we have the UT Health San Antonio up here. They did a really great job of standing in front of our selfie RBC. I love it. It's a really nice picture. And I don't know if it was if their director was the one who put them in front of there, but that's some good Photoshop skills right there. They photoshopped them onto there, so that was really good. I'm impressed. Yeah, that wasn't the actual picture like that. And then we've got the winners of the East this week over here with West Virginia representing us with their Halloween style. So I'm gonna zoom in just because this is great. So UT Health right there. Yeah. They are doing their mad scientist Halloween type of lab. And so
and Michael Myers is behind him too.
Yeah. She looks like she's okay with it. She looks a little embarrassed he's standing behind her. But I'd be a little concerned. I don't know. And so they're mad scientists this week for Halloween. Right down here, we've got, I feel like this is Nebraska, but I don't know, it's Kansas. This is University. Nope, I'm wrong. I was right, it is Nebraska. Southeast Community College is right down here in the front. I like the way they have their classroom set up, where they can have this movable pod-like classroom, and they each have that flat screen. That's really amazing. And then we've got Weber State right here. She brought a friend this time, and we are in front of, we are in front of our selfie guy for the first time, and it's incredible the angle, because it's like this was staged, because you can see both the emblems here. Nothing was cut out by her hair. I think that's awesome. So it's good to see other friends. They're almost twins here with their times. So
Oh, gosh.
amazing job. Yeah.
Like the one to steal their phone for that time.
Yeah. We've got Kansas here, and we've got a mixture of ladies. They haven't always been the same people in the same order, but they always look like they're having a blast. Having a great time hanging out. And I love this mask up little emblem or message on there. So great job, ladies. Then right here we have, it's University of West Florida, and he's enjoying the weather outside. I don't think this is at their campus. It's always hard to tell if they're on
It's
campus.
a pretty campus. It could possibly could be. It looks like
Really?
it. Yeah.
I don't know. I've never been there, but I believe he was the winner of the week with them. We haven't really seen many pictures from them. And then I didn't save the best for last. I think they're the best just because they're mine. But these are my students from the College of Southern Maryland right here. And the reason I say this for last is because this is our trophy that we pass around throughout our competition. So the Cell Bowl started with my program, and we do it every semester, fall semester, when we're in hematology and blood banking. And the idea is for, as you're doing, to use this app to get better at identifying cells. And every week we have a winner in each the first year and the second year classes. And this trophy goes to the winner of the week's bench top during the week. And so they get to be, celebrated and everything. And so we just thought that we would bring the trophy outside to show everybody where this all got started. It's not the trophy you'll get if your program wins, but it is a trophy. So
good to know the origin story. Good origin story.
Yeah.
So they're standing right outside of our lab. Our lab is actually right in there. So this is our refrigerator.
For the magic happens.
There's this corner with windows, and our refrigerator's right in it. If you do that, make sure that you do have good airflow around the refrigerator, because you will end up having heat pockets and it causes problems with your capacitor. So just from personal experience, make sure you've got that good airflow. Yeah, our lab is right on this corner right here. And we are building a new building and going to one of our 5 campuses. We're changing to a central location. And we too, again, get the back right corner lab, and it's going to be gorgeous. And we're moving in there in 2022. So
congratulations. That's
thank
exciting.
you. I'm so excited. And I'm going to have a walk-in fridge, and I won't need to worry about this guy.
So fancy.
Yeah, it's going to be awesome.
Just make sure you have a good backup to that walk-in fridge, because when our walk-in fridge goes down, we have to put stuff in the morgue.
Yeah.
Well, it is Halloween, so that's fair.
It works out.
I do have a funny backup morgue situation story from the hospital I used to work at, but they probably don't want me to tell it on on the recording. So, yeah,
future
but
Halloween,
it was pretty cool. So anyway, we are so proud of everybody. Thank you so much for all of the participation that you have done in the last 4 weeks. And we wish everybody was moving on, but only if you can. I really wish that we were moving on. So close. But make sure again that you are out there supporting who made it. West Florida, West Virginia. We got all our West happening in the East, which is crazy. We were moving on. Kansas, I think that's the right Kansas. We had a couple of Kansases. And so just making sure that you're out there supporting your region and your state and the profession. I think that's pretty much it. If you're continuing on in your programs, make sure that you're letting us know what's going on with you all. Make sure you're participating in the individual competition still. And we hope to keep seeing you in the episodes. Next week, we'll post, like I said, the top 25. We can't post all of the top 6 because that's what the next episodes are on. So stay tuned.
One programming note, because this is sponsored by ASCP. Next year in 2022 is the ASCP Centennial celebration. There has been 100 years of the American Society for Clinical Pathology, and ASCP is celebrating in Chicago next year. Anybody who is a member of ASCP, student or not, is able to attend in Chicago for free. There's no registration to attend the ASCP annual meeting in Chicago next year. And we are so excited to bring you guys that news to the Cell Bowl channel here. It was just announced at the end of the annual meeting yesterday. Actually, on Thursday was when they announced it, and it's all over their social media pages now. So we're excited to announce it here as well. You can attend for free in Chicago for the Centennial celebration.
Exactly.
That is awesome.
Membership. Yeah.
So just to let you know, all 3 of us are on the social media committee for ASCP. So we've been blasting out stuff all during the annual meeting, which just ended yesterday. These 2 flew home.
I was gonna say it ended on Friday. We both flew home yesterday. Did you get delayed, Aaron? Or no?
A couple minutes, but made it.
That was good.
Yep.
So we had to push back filming because it's exhausting to go to these really fun events because everybody has such a great time. So thank you all so much for representing us at the annual meeting and online and interacting with us today and coming and helping out with these students. We are so happy that we're being supported as educators and students, and knowing that ASCP really does care about the future generations of the lab.
Stronger together.
Yes,
it was a blast. As always, it was a blast.
Was it a promyelocyte or was it a myeloblast? Can you be a little more specific, Aaron?
I don't see any peeing. I'm just
no hour rods, you know. You're not pro if you're pink. These are good tips that we learned today. So don't forget them, ladies and gentlemen.
Thank you, Catherine.
See you next time. Bye.
Next time.
Oh, goodness.